with this information for later reference. I have no financial relationships to disclose. So now we can move on to talk about relapse prevention. This is part one of a two-part lecture. So all of you that are here today, hope that you can block it in your calendars to join us again in 2 weeks, same time, same place, so we can finish relapse prevention part two. Today I want to talk about kind of relapse prevention, the model itself, where it fits, because substance abuse treatment providers, we throw that word around an awful lot, or those words, I should say, and it kind of becomes a catch-all for a lot of different things. But it is actually a specific set of techniques or specific model of treating substance abuse. And so I want to put that into sort of where it fits within the how we treat patients. I'm specifically going to go into a couple relapse prevention techniques, identifying and understanding what triggers are, how to explain that to your patients, and then how to help them know how to deal with them when they show up. What are behavioral contingencies? What does that mean, and how to use them? And then how to teach people the skills that they need to manage urges and cravings when they show up. Should I be looking at these chats when they?
No, they'll take care of it.
They'll take care of it. Okay, you guys let me know if any questions pop up. I can always stop. So the first thing to think about, okay, where does relapse prevention fit in? Well, it is what it says. One of the few therapies that is pretty straightforward. We're trying to prevent relapse with these techniques. Now, does that mean that we can't use some of the techniques prior to people actually achieving sobriety? Absolutely not. But it does tend to fit kind of squarely in this maintenance area. You want to start the process of relapse prevention once people get to action. They're actually taking the steps that they need to take to decrease their use, hopefully to an abstinence level, but at least to the level that is their goal. And then we start hitting people with the relapse prevention skills, and that's what helps a lot of folks move into maintenance and stay in maintenance. Now, we do know that relapse is part of this cycle, which is why it's on the stages of change model. It sits a little bit outside of it because not everybody has to have a relapse. When they do, we want to help them walk through it quickly. We don't want them to feel shame or stigma about it. This is an opportunity to learn something new. However, there is a set of really good concrete skills that I can teach you that will help you hopefully prevent ending up in a relapse, or if you do have a slip, being able to get on top of it before it becomes really problematic. So that's kind of where we think about this set of techniques we're going to cover today, fitting within the stages of change. We can also think about where does it fit in terms of staging the treatment that people need. So what we do kind of in the beginning is motivational interviewing and harm reduction. That's what a lot of the science tells us is the best approach. When people are early to treatment, or they're mandated to treatment, or they're not actually in that action phase, they're not totally ready to go, then we want to be working on what do you need to do to stay as healthy as you can today, and using our good motivational interviewing skills to help move them across these different levels. Now, once they're getting into contemplation and planning, then we're starting to see, how do I move this thing? Because it's in my, can I just move it?
Yeah.
Okay, great, good. Sorry, I was blocking my view. Then we're moving into using our core cognitive behavioral therapy techniques, or even if there's a different orientation that you prefer, where the crux of the therapy is going to occur is kind of between numbers 2 and 4. But that's where we're going to be working to move people from that contemplation into action, the steps they need to take to actually start to decrease their use and stop using. And then relapse prevention comes into, okay, you've gotten there, now how do you maintain? What do you do to keep all of these gains? So before I get into the specific techniques we're going to talk about today, I also wanted to briefly identify the core components of cognitive behavioral therapy, because relapse prevention falls under this umbrella. And this is another term, CBT, we throw that around all the time. What does it actually mean? Well, CBT is a talk therapy that really links thoughts, feelings, and behaviors. And I'm going to show you the CBT triad in a minute, so you can really see, like, it's pretty straightforward. There's really good evidence for treating all different forms of addiction, multiple controlled studies for multiple types of substances, as well as people who are duly diagnosed with a substance use and a mental health condition. It's highly flexible, so you can implement it in multiple settings. There's multiple manuals available to most providers that you can pick up easily and implement in a structured fashion. It tends to be short-term and highly focused. So what we want to do is we want people to become experts in their own life, to be able to have the skills to be successful in achieving their goals. And I think CBT is a really nice way of empowering our patients to be able to do that. The other nice thing about CBT therapies is that they work really well in combination with medication or even other modalities. So you could integrate some other perspectives, like an interpersonal perspective, or you could do some grief work, or you could do some things in the middle of doing a CBT protocol and still be quite useful in helping our folks. So in order to understand some of these relapse prevention techniques, I think it's important to understand what's behind it. And to do that, we have to really be clear about this thing called the CBT triad. Now, what this set of techniques is intended to do is to help people understand that things don't just happen and we respond, that there's actually a whole system that occurs within milliseconds that usually we're kind of unaware of. So it's not that something happened and I reacted. It's that something happened and I had a thought about that thing, and then I had an emotion connected to that thought, and then my body responded to that emotion, and then I acted. So really teaching that is core to good relapse prevention, because we want patients to be starting to observe themselves and their behavior and slow things down so that they can begin to intervene more effectively. So a good example that I'm sure most of us have experienced with this, with how quickly this system can come into play and kind of take over. Some of us might have even experienced this morning. Is I want you to imagine that you're driving to work and you're on the freeway and somebody cuts you off in traffic. Now, what are you likely to think? For a lot of people, they'll probably think, what the heck, that jerk, I can't believe he just did that. So what emotion are you probably going to feel? You're probably going to feel maybe some initial fear because he jumped in front of you, but then you're also going to feel anger. And then associated with that emotion, you might have a surge of adrenaline, your heart might start racing, you might get a little hot or sweaty. And then what are you going to do as a response to both thinking, what the heck, that jerk, I can't believe he did that, feeling pissed off, having a surge of adrenaline going through your body? You're likely to step on the gas and tailgate the guy, right? Or honk the horn or flip him off or do any number of behaviors that maybe you're not so proud of. We've probably all done this at some point in time. Now, let's take the exact same situation, going to work, driving down the highway, somebody cuts you off in traffic, but you have a different thought. You have the thought, oh no, I hope he's okay. I hope that person isn't in trouble. Now, that's same exact situation, completely different thought. What am I likely to feel in response to that thought? I might feel some initial fear because, again, he surprised me, but it's probably going to be followed by concern or compassion for the person. I might have a little bit of adrenaline from that initial shock of the person jumping in front of me, but it's not going to be followed by the same intensity of feeling hot or uncomfortable or my respiration increasing. I might actually start to calm down pretty quickly. And then what are my behaviors going to do? Well, I'm likely not going to step on the gas and start honking the horn. I'm likely to take my foot off the gas, and I'm going to give him some space, because that's coming from that concern and that more relaxed place. So that tells you right there the power of our thoughts. And that if we can teach people that core skill of being able to intervene at the level of what they're saying to themselves, they have control over everything that occurs down the line. And that's particularly powerful when it comes to helping people understand the effect that triggers have in their life, and how they can manage urges to use when they occur. So what the triad is talking about are those three things. You always have a thought before you have a feeling, before you engage in a behavior. Okay, so now let's talk about triggers, understanding external and internal. So this is the stuff that sits outside. So that environmental stuff, the activating trigger that sits outside of the triad. What are these things, and why is it important to educate our patients on what their particular triggers are and how to work with them? Well, before we can talk about that, we have to talk about classical conditioning, because this is really important to understand why triggers are what they are. So I bet most of you at some point in school were exposed to the Pavlov's dog's experiment, and have some understanding of how this works. So essentially, what happens in most mammal brains is we respond to things that are unconditioned, like food, like loud noises, like things that are going to cause a reaction in our body system because of how we're wired. So for instance, if you have a dog and you expose them to food, they're going to salivate. I mean, that I could say the same as for human beings as well, right? That when we smell that pizza in the break room, we're probably going to salivate, right? So that is a unconditioned response to a natural stimulus. Now, we don't have that same response to something that's neutral. So for instance, like a whistle or a bell, we're not going to salivate to that because there's no relationship there. But if we pair those things and we pair them repeatedly, so if we combine the whistle or the bell with the food, then they're going to become linked. And they're gonna, somebody's not muted. And that's going to elicit the same unconditioned response that the food did by itself. And then eventually, if we do that enough, or we do it with a high enough intensity unconditioned stimulus, then we can elicit the response without the food. So essentially, we've linked them so sufficiently that the brain is going to respond to the whistle the way it did to the food. So how does that respond to drugs? Well, pretty much exactly the same. And I would say on a really, really powerful level, because drugs hijack our brain unlike anything else in the natural world. So if we have the same thing, like things are going on in the environment, neutral stimuli, right? The situation that we're in, the sights, the sounds, the smells, the stuff that's even going on internally for us, that's happening at the same time that we are experiencing the effects of a drug, then that is going to become linked. So we take that neutral stimuli, we pair it with the drug, and we get a reaction to the drug, whether that's euphoria, whether that's a relaxed state, whether that's eliminating pain or avoiding some kind of psychological pain, whatever that is going to be elicited when those things are happening at the same point in time. Now, when we remove the effect of the drug, because it is such a powerful stimulus, and probably because people have repeatedly matched these things together, what's going to happen is that stimuli that's in the environment, the foil that's crumpled up on the table, the needles, the cotton, the street that their dealer lives on, all of those relatively neutral stimuli get so paired with the effect of the drug that they have the same response to it. So that's where the drug craving comes in. And we've actually been able to show that in people's brains, even just thinking about going to their dealer's house, or even just looking at the crumpled up foil on the table, they start to smell the smells or feel a little bit of the euphoria. They actually start to have the high sensations or the relief sensations associated with the drug with absolutely no drug in their system. So we know that that is happening. So essentially what's going on with a big part of addiction are these repeated pairings of events, emotional states, and all of the things that are linked, all of the people, places, and things that we tell people to avoid, because it is going to produce the same intense craving as the drug will produce itself. So over time, stuff that that before was not problematic is problematic. Money, parts of town, even a lot of my patients, they cannot keep foil in their house because it's a huge trigger. Times of day, certain emotional states, not being able to tolerate experiencing anxiety or loneliness or boredom. Those are all things that have become paired with the effect of the drug and will trigger it by itself. Now, we know this as mental health providers, but I think another organization that has known this for a very long time to our disadvantage is the advertising world, right? So I want you to imagine how difficult it must be for some of our folks who may have had financial struggles because of their addiction, may not be able to get a bank account or keep a bank account. What happens to them when they have to go and get gas? They're probably not going to be able to buy gas at the pump. So they're going to have to go inside and pay. Now, what are they going to be confronted with when they go inside? They put their money on the counter, which is probably a trigger. And what's on the counter? All kinds of scratch-offs. And what's next to the scratch-offs? A thing of lighters. And what's behind the guy at the counter? Alcohol and cigarettes, right? So you can imagine how difficult it has to be just to go about your daily life when these things have been linked. Or for some of you, you might have experienced this when you're checking out at the grocery store. There's a reason why there's candy on that aisle. That is done for a reason, because we have these links going on all the time. So what are we doing therapeutically when we're talking about relapse prevention is we're taking all of that information and we're trying to explain that to them in a way that's meaningful, in a way that they can work with it. So we want to understand what all those links could possibly be. And the best way to do that is this thing called a functional analysis. And that helps us to collect information on drug set and setting. So essentially with a functional analysis, what we're trying to get at is the specific triggers associated with the drug. So what did they use? How often? What was the amount? Is it legal? Is it not? That's gonna inform your what your triggers are, the type and quality of the substance, right? So the difference between China white and black tar, they're different colors, they smell different, they look different, right? So those are going to be different triggers. We also want to understand the individual person's what's called set. So the thing that might be going on internally for them or be internal triggers, their physiology, their health, their mental state, their culture, what stage of change they're in, what their history of use is, why they use, right? If I'm using to avoid psychological pain or physical pain, those might all be triggers for me. And then we want to understand their setting. So the place that they use, who they use with, what stress is there at the time, what support is there at the time, and how they interpret it. Do they interpret it as this is something fun, right? A lot of people think about alcohol as a good example. Some people struggle to they're triggered to want to drink only when they feel sad and lonely and all of this negative affect. And other people are triggered to drink when they're happy and they're excited and at birthday parties and weddings and New Year's, right? And so both of those things are opposite ends of the spectrum, but how I interpret my use could be very different. I interpret my use as I'm so ashamed, I'm a bad person because I have to use this to cope, versus there's nothing wrong with me because I use this to have fun and to party and to be myself, right? So that's an important one, understanding why somebody does it. So what do? We have to do this thing called a functional analysis to get that information. And via that tool, we're going to examine and explore the long and short-term positive and negative consequences of the drug. So that's getting all that information. And then that helps us to develop the positive reinforcements or the behavioral contingencies that we're going to talk about next. which is really important. So this is an example of a functional analysis, and I gave you guys, I think one of the things that was sent out is a Word document that is a standalone session on how to do a functional analysis, and there's 2 different functional analyses that are provided in the worksheets. Can I minimize this to show them that?
So just hit,
okay.
There you go.
So if you check your email, it's this one. It looks like this. I don't know why this has popped up. So this is something that you can.
You guys will have to do a new share screen to see the next one. Yeah. And then they'll get these sheets in the post-clinic email. Yeah.
Share screen.
And then find the document that you want to look at.
All right. I'm going to figure this out, I promise. Okay. There we go. So this is a because, I mean, functional analysis is bread and butter in CBT. You'll find it in most CBT manuals, but I just wanted to, for those of you who might not have a manual or that's a little unwieldy to grab a manual, this is a standalone session. It's a nice little quote that you can do for intro to discussion, but talks about what functional analysis is in terms for them. So these are handouts you can give to them and you can go over with them, explaining triggers, behaviors, positive and negative consequences. And then this is the functional analysis that you'll do together. And then this is one that they can actually practice. So there's one on their use and one on pro-social behavior. So things that that actually might be reinforcing and engaging other than substances. So I just wanted everybody to see that. Okay, stop share.
Perfect.
Then I go back
And then go
to
back.
share.
There
Haha,
you go. Perfect.
I got it. I'm totally getting this. Okay. All right. So essentially what you're doing is you're identifying the external and the internal triggers, and you can ask much more questions than this. These are just the basic questions that you ask to start to get that conversation going, to make that list of triggers. Then what are the behaviors associated with the triggers, and what are both the short-term positive consequences and the long-term negative consequences that are associated with it. So once we have an idea of what their triggers are, then we want to help them work with that in a meaningful way. Now, ideally, if we're doing relapse prevention, they've at least started to decrease their use or they have stopped their use and we're wanting to keep them there. So this is something called a self-monitoring recording log that you can use for daily practice. Because remember, they're having to change their brain. And that is not going to happen in a once a week or once a month therapy session. That's going to happen by doing daily practice, because they have linked all of these triggers to that drug hundreds of thousands of times, and that's going to take a while to loosen up and start to break the connections. So this is really great to give to them, to say, I want you to do, I'm going to give you 7 of these. I want you to do at least 1 a day, and fill it out and bring it back, and we'll talk about it. So this is where you have them identify what was the trigger that happened, what did they think and feel when it happened, what did they then do, and then what happened as a result of what they did. So this starts and you can do it both with use or without use. So I drove down the street at my dealer's house. That's the trigger. I thought, man, I really want to use. God, I'm such a loser that I've been using. I felt anxious and sad. What did I do? Well, I either pulled into the driveway and scored, in which case the positive consequence was I got high and I could avoid it for the moment. And the negative consequence was I felt ashamed and my partner got super mad at me because I slipped again. Versus another behavioral option might be I kept on driving, right? That was what I did. What's the positive consequence? Well, I was a little anxious for about an hour, but then I was able to calm down. And I actually felt really proud of myself. And then the negative consequence was nothing, right? So we can teach this skill to them and have them practice it both if they're using or if they've stopped using. This is another version of that to help them start to think about including not just the thoughts and the feelings, but also the body sensations. So I just wanted this as another option. And you can see with both same situation, same exact trigger, different thought. That's what contributes to the whole rest of the chain. So if I wake up depressed and I say to myself, God, I always feel bad, and then I feel sad and I feel disappointed, I'm probably going to have some physiological reactions. Then I'm probably going to use, right? I'm going to use whatever the drug is, and then I'm going to have some negative consequences associated with it. Same exact situation, but I changed my thought. I can get through this. Then I'm going to feel different. I'm going to have different body sensations, and I'm probably going to engage in different behavior. So you can show this to patients to say, look, there's tremendous hope here, and you have a lot of control. This has nothing to do with willpower. This has nothing to do with putting yourself in the situation and setting yourself up to fail. This has to do with taking control of how your brain is working and starting to change it to be in your best interest. Okay, so that was triggers. Now let's blend into, once we've identified the triggers that are causing the urges, what do we do with this thing called behavioral contingency? So helping people to understand that they can do something else and reinforcing that. So I feel this way just with coffee instead of a carrot. It's the only way I can get myself out of bed in the morning. Gotta have it, right? So as human beings, this is pretty much how we're wired. We tend to do things because we are either reinforced or we are punished in some way. And B.F. Skinner was a behavioral psychologist who figured this out, him with some other people. And he basically said, most behavior can be changed if we partner it with either rewards or consequences, right? What we know is human beings respond exactly the same way. Multiple studies have showed this. They've showed that rewards will increase a desired behavior. For those of you that are parents, you've probably practiced this a lot. Like if I say, good job, awesome, you get a sticker, I'm going to see more of that behavior than if I ignore it. Punishment also works. Punishment or sanctions will decrease an undesired behavior, or a removal of something that the person wants, taking away a privilege, that will decrease an undesired behavior. However, and I think this is a really, really important thing as clinicians to understand, the effect from reward is significantly more pronounced and longer lasting. Now, as substance abuse providers, we have a long, long history and culture of punishing people, of shaming them, of criminalizing them, putting them in jail, removing them from their families and their communities. And if that worked, if isolating people and punishing people worked, we would not have the problem that we have. So obviously it doesn't. And we can have a whole nother lecture on another day about why it doesn't work. But let's just say for time, this is not an effective way of helping people change. And it's important to explain that to patients because they punish themselves. So we want them to unhook from this idea of if I'm nice to myself, if I reward myself, if I say good job, I'm going to slip. I don't deserve it. I have to be hard on myself. I have to be cruel to myself. That is not really that effective. So what do we want to do? We want to think about clearly identifying with them, both that as the provider, but also for themselves in their life, what do they want to work on? What are the targets? And we talked about this when we talked about treatment planning. People are not very good at setting realistic, achievable goals for themselves. I know I'm not. I think most people are not. We think really big and we bite off way more than we can handle and we set ourselves up to fail. So when we're thinking about behavioral contingencies and how to apply those clinically, we have to think the same way. Small scale. What is the smallest unit of achievement that we can reinforce? What is that small accomplishment that they can get a little reward for doing without that much effort? Because then they're going to do more of it. And the more of it they do, the more successful they'll be. So in a lot of clinics or a lot of systems, the low-hanging fruit is attendance and UAs. And you can think about this depending on what system you live in, but for sure, attendance. They either show or they don't. Their UA is either negative or it's not, right? So it's a really clear target to hit. And you can think about there's variable ways to set this up so that you can use behavioral contingencies to essentially reward or reinforce the behavior you want to see. Now, at ASAP, we solicit donations, we write grants, we do a lot of the things to try to get money to have what's called contingency management, to be able to actually give people vouchers or gift cards or prizes for some of these behavioral targets. You might not work in a facility that you have that kind of funding. That's okay. That doesn't mean you can't still use this intervention. So you could do something as simple as every time they come and see you, they write their name on a piece of paper and they put it in a fishbowl. And at the end of the month, all of your patients' names that have been put in that fishbowl, you're going to draw one, and they get, I don't know, they get a fruit basket, or they get a bag of groceries from Smith's, right? They get something that that the employees have pitched in to donate $10 for. That's a huge deal and will go a super long way. Sobriety chips is another one, and there's a reason why AA uses them, AA and NA, is because it's a small, physical, tangible token of achievement. I did this, I made this. But something you can do that's absolutely free, and that I really, really encourage, and I think substance abuse providers do such a good job of, so keep doing, is public acknowledgement and just being positive. So the second you see them, no matter how rough they are, no matter how they've slipped, no matter how down in the dumps they are that day, find something that you can reinforce, something that they have done well, even if it is just that they are there in front of you. Hey, you came today. That is freaking awesome, right? So reinforcing that and teaching their family to do that will be a really significant shift. We also want to do this as a big part of relapse prevention, because the more we reinforce that behavior, the more likely it is going to be maintained. So thinking about how to shift from you get a prize or you get an award for coming to clinic for your attendance to how do I now help them translate that to I get a paycheck for going to work, right? How do I now translate that to I get acknowledged at my church when I volunteer on Sundays, right? To pro-social engagement that is long-lasting and much more sustainable for helping people avoid relapse. Because at the end of the day, anybody can choose to relapse at any time. And there are probably tremendous stressors going on at any given moment that could cause them to relapse. They're never going to be able to avoid all those things. But the science tells us that what really helps people stay sober and in spite of those stressors, not just the skills that they've learned, but it's the connections that they've made. So knowing that they have to get up and go to work in the morning, knowing that their family is depending on them, knowing that they take pride in being somebody who doesn't do that to themselves, that they love themselves enough. Those are all connections that are variants of these behavioral contingencies. So just like we talked about here, where we're helping people to see that connection between the trigger, something happens, I have a thought, I say something to myself, all the way to the end, the consequence. We want to start them to think about changing that consequence. So an expression from AA is called think through the drink. So we can say think through the drug, right? I want you to think all the way from I drive down the street to my dealer's house to having used, all the way from I drive down the street to my dealer's house to doing something else. And I want you to put yourself in that place and actually imagine what that would be. So one technique that you can use to do that is this alternatives to use table. So helping them write out, and you can do this every single week, write out the potentially triggering situations that are coming up. We'll talk a lot more about this when we talk about high-risk situation planning next time. But we're essentially having them think into the future, what is coming up that could be a triggering situation, and what would be the consequences of using in that situation? What would feel good if you were to do that? Because I can't match it with a replacement until I know what it is you're going to get out of it. So if the positive consequence of being at the party is I felt like I was able to join, I felt like I was there, I felt more relaxed, now I have to think about the alternative needs to be something similar. It needs to be something of similar weight. So say an alternative would be, instead of going to the party, and using. You don't go, but you get some food and you go to a movie with your boyfriend. What are you going to feel? Well, it might not be joining a group, but it's joining with your boyfriend. It's that connection that we're helping to meet. And hey, instead of feeling bad that you used, you're going to be proud that you didn't use, right? So you're helping them to think all the way through to what those consequences are and identify their specific behavioral contingencies that are going to reinforce and reward them for not using in those situations. So this is just an example. You can recreate this if you think that this would be helpful for you. The other thing that I encourage people to use when they're talking about contingencies is thinking about the hundreds of different activities that we want our patients to try, to experiment with, to start doing instead. And I'll be frank with them. I'll say, listen, I am not going to tell you that yoga or going for a walk or having a good dinner is going to come anywhere close to heroin. It's not. Nothing is ever going to feel like heroin. I'm not going to lie to you about that. However, there are things in life that do feel good. And if you do enough of them and you do enough of them over time, eventually that the power that heroin has over you, it's not going to be as appealing, right? So I think that this is an important list to have somewhere on hand. I also want to throw in the caveat that rather than taking this as an example, obviously for probably not most of the populations we work with, doing needlepoint and going to gym might not always be accessible to our folks. But thinking about a list that is culturally relevant, so the population that you work with and the community that you work with, what is available to them? What are the organizations and things that they can do for free, that they can get to with public transportation? What are the things that might be connecting them to their community, right? Specific cultural events. Is somebody's phone going?
I don't know. That's what I'm trying to, let me pause.
Activities that you can pull out and you can say, what are you willing to try this week? What are you willing to do the next time you drive down your dealer street instead? Because setting them up to do nothing, they're probably not going to be very successful. We want to set them up to do something else, right? And this I just wanted to throw in here quickly. This is a program that we have at ASAP to help you think about, if there's any administrators in the audience, how do I implement a contingency management or some behavioral contingencies in my system as a system. So identifying what are those specific behaviors we want to change, like negative UAs, coming to an appointment. One option is you can do a fishbowl approach. So you can say, right now, I'm going to reinforce you right now. You showed up, you get to pick out of the fishbowl. Now, you set up that fishbowl strategically so that a good 80% of it, they just get a little piece of paper that says, good job, awesome, keep going, you're fantastic. A smaller percentage, they might get like a 25-cent Snickers bar or something. An even smaller percentage, they might get like, I don't know, a shampoo packet from the dollar store. And an even smaller percentage, they might get something big like a tote bag or a gift card to the grocery store or something. So what are we doing there? We're reinforcing them immediately. You get something for coming, right? I did something, I get something positive immediately. But we're also setting it up to say, the chance of you getting something really big each time is not very high. So what you can do instead, if you choose not to get the reward right away, is you can bank your point. Now, what happens if you bank your point? Well, we're going to track it for you, and it's going to be additive. So each week you come in and you get a point. Next week you come in, you get 2 points, so now you have 3. The next week you come in, you get 3 points, so now you have 6. Why would this be where we want to move people? It's because delayed gratification is a skill that we get in childhood and most of our patients did not get, or it has been eroded because of their drug use. So this is something that will teach them how to do that, how to start to postpone gratification for bigger and bigger prizes. And the more points they get, it's like Chuck E. Cheese, right? If I go and I redeem my 10 tickets, I'm only going to get the little plastic toy. But if I wait till I got 250 tickets, I'm going to get the stuffed animal behind the counter. That's what we're trying to teach them. Because for most of us, we take for granted all of the things that we need a delayed gratification to do. You have to be able to delay gratification to get a job, to buy a house, to buy a car, to go to school. All of these things we don't get immediately reinforced for. We have to wait for that payoff. And our patients don't necessarily have that skill set built in. And so they really struggle day to day. So if you can use behavioral contingencies as part of your overall relapse prevention, you can start to build that in so that they're learning that while they're moving through their recovery. So last thing, I want to talk about urge management. A lot of you probably already do this, but this is a core skill for relapse prevention. So this is where we teach patients how to identify and modify their urges. So again, at that level of thought, we want to change the thought because then that changes the behavior or the consequence. How do we do that? Well, we got to start by recording their urges. So this is an example of a daily urge record where we're asking them again daily to practice. Write down the date, the situation, or the trigger. What are the thoughts and the feelings associated with the trigger? And then what is the craving or the urge level, 1 through 100? How intense was it? And then what did you do with it? Did you use, did you not use? Did you use one of those other behaviors that we've talked about? What did you do instead, right? So this is where we're just like with the functional analysis, we're getting data. What is their urges and cravings at the moment? Now we would move into a maybe more involved one, and this is just an example that comes from drinking, but you can modify this for any drug. So this is where we're looking at their drug use and their urges. So somebody who's kind of in the action phase, they're still cutting back, they're not completely sober, but we're moving into maintenance. We're looking at, did you use any drugs? Yes or no? If so, how much? What was it? And then what were your urges to use? And you can rate the intensity. You can also list the situation related to it and the thoughts and feelings. So it's kind of like the other worksheet, just a little more data and in reverse. And this is just a blank one. And so what we're teaching them is to start to identify urges as these very specific things. It's not a guarantee that you're going to use. It's actually a natural experience associated with change. I don't know anybody out there, if you've ever tried to diet and then you're like, I am committed. I am done with sugar. I'm never going to eat another donut. And then you come to work and what's in the office, right? You're like gonna want to eat the freaking donut no matter how committed you are, no matter how motivated you are. That's a natural part of change. And so we want to educate them about that external events, they have been linked over time. They're unavoidable. The vast majority of them are. So you're going to have urges that come along when you're triggered. And all it is a signal that you need to do something. You need to do something differently because living in a vacuum and waiting is setting yourself up to fail. The other thing we want them to really hammer home is this is time limited. Even if you choose not to do something, you choose to do nothing but sit and not move, it will pass. Right? Better to do something, but even if you just don't take action, it will pass over time. So these are just some how you would talk to a patient about it. We explain it. It's like trying to fight a wave in the ocean. How smart is that? How successful are you going to be? Not very successful. You're going to be a lot better if you could just ride on top, if you can just surf them instead. So that's how we want to think about it. These are like waves in the ocean. They come, they go, they rise, they fall. We don't have to be beholden to them. Most of us have them, they pass. It usually within 20 to 30 minutes, oftentimes it's even faster than that, especially if they do something else, it will pass faster. And just know it's going to come back, but hey, it's an opportunity to practice. Every time you surf that urge and you don't act on it, you're going to get better. And that urge is going to become less intense and less frequent over time. It's kind of like every time somebody has an urge and they use because of the urge, we've now reinforced the urge. So it makes it stronger. It's like putting lighter fluid on a fire. So what we're teaching them is to say, hey, the fire is it's gonna spontaneous lightning strikes, the fire's going to start. But if we don't pour any fluid on it, if we just leave it alone, it will burn out. That's all we have to do is leave it alone. This is one example that you can use to have them start recording what will I do instead, right? When an urge comes up, what can I do different? And then this is another example, and let me just stop share. Well, I gave this to you guys also as a worksheet. I don't need to stop share. And this is a handout that you can give to patients that I think is super, super helpful. One of the links is a standalone session on urge management that walks the patient through how to teach them this technique. And then this is just a standalone worksheet that kind of does a lot of the same stuff. It's basically saying most people have urges when they first quit in the beginning. They can get very intense. The good news is they get easier over time, right? They get easier to ignore the longer you do it. Their reactions to the triggers, which we've already talked about, and it's an opportunity to do something different. So there's a couple techniques. If you don't want to use this, they come up with it themselves. If they struggle to come up with what do I do instead, this worksheet gives you a whole list. I'm going to check the ones I'm going to try. I can remind myself that it's temporary. I can try to get away from the situation or get away from the trigger if it's possible. I can go through all the reasons why I decided to stop using in the first place. I can find something to do to take my mind off it, to distract myself. I can call somebody who's going to understand and just say, man, I really, really want to use today. Just help me talk about it. I can say encouraging things to myself, like, you got this, you can handle this, it's going to pass. Notice beating yourself up is not one of the options, right? I can use my imagination to take myself to a happy place. This is another particularly helpful one. I can use my imagination to imagine that I'm some kind of samurai, and the urge is this monster or this bad guy that I'm like beating back, and I'm totally powerful. I can totally handle it. Or an even more powerful one is to imagine something really awfully nasty in the drug that they want to use. Thinking about the syringe filled with bleach or filled with acid or something that you absolutely would not want to put into your body. So you can imagine if you're walking down the hallway and you see that box of donuts and you start to think some pretty nasty stuff is inside those donuts, you're not going to want to eat them, right? So that's the same technique, we just apply it to drugs. So this is a nice worksheet that you can give to them as a standalone way to do urge management. So that's all I got, those 3 components of relapse prevention. Who has questions?